Thank you very much. It's fantastic to be here, to be amongst friends and colleagues, and people who over the years have been prepared to raise their voice and to attempt at least to speak truth to power. That's a very difficult thing to do. It's a very difficult thing to keep it going. So it's really important that people like Carina and Hannah and Alexandra and this movement that we're trying to create is supported, and it's fantastic to see so many people here today. So I'm going to talk to you from my perspective as a child psychiatrist who continues in practice, who sees young people and their families, and who's also a trainer. So I do a lot of supervision. I work with a team. I also do training for young psychiatrists, trainee psychiatrists, and child psychiatrists who are training to become consultants. And I'm going to speak a little bit about some of the dilemmas that I face. And these are dilemmas that I don't have solutions to, but I'm going to talk to you about some of the ways that I've tried to engage with those dilemmas. Because I think when you're dealing with real life, it's messy. And when you're dealing with how you negotiate with people, it's messy. And I don't think we can escape that. And there are three dilemmas in particular that I wanted to highlight. One is the dilemma that I have of I inherit people frequently who have been prescribed psychiatric medication by other agencies. So how do I work with them? They've already been cultured into a way of thinking about what's going on in their life and what the solutions are. So how do I work meaningfully with them? Another dilemma I have is that, sadly, in our culture more broadly, we have been exposed to a lot of, you might call it propaganda, but a lot of stories about the importance of psychiatric medication. So people come to my service, often expecting that a diagnosis will be helpful, and often expecting that there is a medication that will help alleviate the distress that they're feeling, either about themselves or about their children. So how do I deal with some of those dilemmas? And the third dilemma that I have is in my role as a trainer. So the people I'm working with in terms of training, how do I introduce them to models that is not going to be so disruptive that they're unable to work with the teams that they're working with? Because as trainees, they're working with other teams, they're working with other psychiatrists, they are prescribing medication, they are making diagnosis. So how do we get alongside and, without being too disruptive to their experience, but at least giving them an opportunity to rethink some of those things in a helpful way? So these are some of the dilemmas which I say I don't have a particular magical solution to, but I'm going to introduce you to a few of the ideas that I've had in how I've tried to engage with some of these dilemmas. And so what I'm going to cover is, first of all, look at some of the basic assumptions that are often present when we're working with people with the types of problems that are presenting to us as mental health practitioners and particularly as psychiatrists. I'm going to cover just bits and pieces of the evidence in relation to some of these things, in relation to that kind of basic assumption that sits behind these frameworks. And then I'm going to look at a few working examples of how I've tried to engage with some of these dilemmas that I've just mentioned. So, for example, I'm going to look at something that we call, and people popularly call, antidepressants or antipsychotics. Of course, there's no such thing as an antidepressant. There's no such thing as an antipsychotic. These are just marketing tools that have been developed in order to sell the idea that there is a specific treatment for a specific condition. So these are just chemicals that do certain things, and they do it to everybody. They are not specific chemicals that have a specific action on a specific disease process. And I'll say a little bit about that. And again, how I've tried to work with some of these issues. So, let's consider frameworks. When I do training with some of the trainees that I work with, this is the sort of example I use. I get them to sit together in pairs or in groups and think about this. Let's say you have a patient. They present with persistent low mood. This is an example that would be fairly typical from the sort of practice that is common in the UK. They've been for cognitive behaviour therapy with a service called IIPDW, which is Improving Access to Psychological Therapies. It's a big project in the UK. However, the cognitive behavioural therapy didn't help, and now she's been referred to the psychiatrist, and her friend thinks she needs an antidepressant. Her friend's on an antidepressant. It's worked for her, so that's what she thinks she needs. And let's assume you decide to prescribe this thing called an antidepressant. How do you explain this to the person? How do you explain why you're prescribing what you're prescribing and how it works? And you know, one of the amazing things that I've discovered in the time that I've been doing trainings is that things haven't changed much from the time that I was trained as a psychiatrist. We actually don't get taught how to talk to people, how to explain things. We follow an idea that this is a prescription. We've diagnosed a condition. This is a prescription we give. We often say that you need to take this for at least 1 year, and then we'll take you off it if you're feeling better. But if you have a relapse, it probably means you need to stay on it for many more years, possibly for life. That's the kind of model. And that's about it in terms of what so we don't get much help in how we explain things. We don't get much help in understanding how we engage people, what words we use, how we might taper people off, what alternatives we might think about, how we might do other things alongside the medication. So this is one of the areas that I found that there is a really good way in, because this is something that a lot of psychiatry trainees really struggle with. And generally what happens when I introduce this sort of exercise is what people come back to me is they try and do something around a chemical imbalance idea. So they come up with descriptions like, they'll tell the patient, what's probably happening is that you've now got a chemical imbalance in your serotonin's system, and these medications will work by correcting that chemical imbalance for you, and that should help you feel better. Something like that. That's the model they tend to come back with. So I talk about some of the basic assumptions. So the first one I explain to people when I'm working with them, trainees, is that if the aim of what you're doing is something about trying to shift someone's mental state, it is psychotherapy. So there is this idea that there is a distinction between something we call psychotherapy, which is something some people do about talking to people in strange ways and helping them understand something. And then there's something that the real doctors do, which is not psychotherapy, it's called pharmacotherapy, which is addressing something of the biological nature of some of the problems they're experiencing. So I do cover some of the evidence that actually nobody's come up with anything that shows that people are suffering from chemical imbalances. And that's illustrated by the fact that we don't send anybody for any tests for chemical imbalances. It's purely an assumption. So the first thing I tell people is that whether you like it or not, when you're prescribing something that you're calling an antidepressant with the intention that you're hoping something will shift in somebody's mental state, it is psychotherapy. Sorry, you can't avoid it. You do psychotherapy every day, whether you like it or not. So you're going to have to think about what is the meanings that might be attached to the way that you're prescribing. How do people think about and understand what's going on? How does a prescription fit into people's meaning-making framework? And I do say that actually this idea that you've come across from what the little scenario we just been through, that you've explained that it's a chemical imbalance, is probably the worst framework you could prescribe in, because it's introducing the idea that it takes an external agent to shift things rather than something that people do themselves. This is the way we create chronic patients, by accident. You know, you have to remember, most psychiatrists are doing what they do because they are people with intentions, genuine intentions of wishing to do what they can to help people who are struggling, are in distress. They're not bad people. You know? It's just the things that we've been taught don't make sense. They don't follow the evidence. And they tend to result. Why we have these models that think of things like depression and recurrent depression and schizophrenia and bipolar disorder as chronic long-term conditions is because that's what tends to happen to patients who come under our purview, who tend to come and find ourselves repeatedly seeing them over the years. So we've constructed this idea that they are chronic diseases because that's what seems to happen. And these are the sorts of models. The chemical imbalance model is one of the sorts of models that invites people to become chronic patients. Does that make sense? Yeah. So I introduce people to some of the evidence. So some of the evidence that there's this thing that's known from research, the outcome research, called the lab-clinic gap, which is the gap between what research says should be happening and what actual research in terms of real life services, mental health services, is finding. So according to research, large numbers of studies on what we might call the common mental health problems, depression, anxiety, so on, around 50 to 70% compared to a no intervention group should be doing better. This is quite a large effect. If you follow people long enough, if you follow people for about 1 year to 2 years, a lot of that no intervention group will eventually catch up. So I think there is something in here about good therapy, good psychotherapy, as being something of a catalyst. It does help people come out of states of distress quicker than people with no intervention. But if we look at what's happening in actual real life services for mental health, we find a quite depressing picture. So a large review of outcomes for community mental health services in the US, for example, found that about 3/4 of people who are entering the mental health services were recording either no improvement or a deterioration. Only 25% were being recorded as having significant improvement. We look at some services, they have some very high dropout rates. So some studies of services with child and adolescent mental health found dropout rates as high as as high as 60% of the people who attend the service drop out of treatment at some point. In other words, they're discharged because they don't turn up. So there's something also about our ability to engage with services. If you look at some of the public health projects that have been out there. So an interesting one is the Beyond Blue project in Australia, which has been going on several decades. And there's been an independent team that's been evaluating the outcomes. So they found that over the last 2 or so decades of this project being around, which was about increasing mental health awareness, about boosting up services, about improving screening in general practice, they found that even though availability of services have doubled, the number of treatments, number of people in treatment has increased enormously. Outcomes hadn't actually improved. What had changed was the number of people taking medication. That was the biggest change that happened. And then they started finding some very odd findings. So, for example, if you were categorized as having what they termed poor mental health knowledge, it actually turned out to be a protective factor in terms of your likelihood of recovery from whatever condition you were presenting with. That is, people who rejected the idea, for example, that depression is an illness, people who rejected that idea, in other words, were much more likely to recover than people who accepted that idea. So, I think this is important for us to know about, for those of us who work in services, because, yes, of course, we have problems with access, we have problems with funding, we have problems with being able to deliver the sorts of interventions that people are looking for. But the problem isn't just funding. If we just keep increasing funding services that actually don't work, all we're going to do is create more and more problems. So it's about funding what sort of services that we're funding is an important, much more important thing. You'll probably hear from Robert Whitaker a bit later about the other bits of data, about the increasing numbers of people who are categorized as having long-term mental health problems, who are then categorized as being disabled by those mental health problems to the extent that they are requiring state support. So a recent review from the UK looked at the different reasons for people drawing what we call disability benefits because of a medical condition. So back in 2011, mental illness became the leading reason for drawing disability living allowance in the UK. And whilst the numbers who are drawing disability living allowances for mental health problem reasons has been steadily increasing, most other conditions have been steadily going down. So that, for example, musculoskeletal problems like back pain is the second most reason, but it used to be the highest reason. That one has been steadily going down. So in other words, with most other medical conditions, what we call the prognosis, which is the likelihood of getting better, has been improving, whereas for mental illnesses, the opposite seems to be happening. And I suspect Robert might say something about this pattern seems to be replicated across countries that have the most developed mental health services. So we seem to have become good at creating long-term patients. And I think that's partly because of the models that we use. And so the model that we use is what I call the technical model. And this is the idea that in psychiatry, we can follow a way of working that is similar to many other branches of medicine, where we have a system of classification that matches our diagnoses to particular conditions and therefore becomes the basis for choosing the correct treatment. That is the technical model in its most simplest. In other words, our classification links in some way to causes, and our treatments links in some way to addressing those particular causes. Does that make sense? Yeah? So in this technical model, it's not that other things are ignored. It's not things like contexts are ignored, relationships are ignored, or outcomes are ignored.
but they form a secondary function. They form a secondary function, so they sit outside what you consider to be the primary goal of your intervention. So in the technical model, you make a diagnosis, you look to the correct guideline to follow from that diagnosis. That tells you the process to follow, what treatments you should recommend. And the emphasis then in the treatment is using particular techniques, whether it's an intervention pharmacologically or psychologically. Yeah? So that's the kind of basis of the model. But actually, if you look at the data, there is no such thing as a psychiatric diagnosis. I'm very clear about that. This, I think, is a truism. It's not to my mind, up for debate. And I'll explain why. If you look up in the dictionary what medical diagnosis means, you'll find that what it refers to, diagnosis is an explanation. It refers to an explanation for a set of symptoms. And I can compare how you would approach that if you had something like diabetes compared to, say, something like, as a child psychiatrist, I would deal with things like attention deficit hyperactivity disorder, ADHD, for short. So if I ask the question, what is ADHD? The only answer I can give is a description of behaviors. So ADHD is hyperactivity, impulsivity, poor attention, however you want to define the cutoffs or whatever, with a few other qualifiers. So I cannot give a definition that is beyond a description of behaviors. Okay? If I ask the question, what is diabetes? And I stuck to a description, I would be in big trouble as a practitioner. So if I said, oh, diabetes is being thirsty, going to the toilet a lot, and fatigue, I would be in big trouble. Why would I be in big trouble? Because other conditions can present like that. And diabetes may not present in that way. So what would I do? Well, what I would do is I would arrange for some tests. So I would arrange what I call for independent data. Data that's independent of my opinion. Now, I still have to go through a process of testing hypotheses and trying to figure out. So diabetes, of course, is to do with sugar metabolism. So I might arrange for a urine test, a blood test, looking for glucose, looking for ketones, whatever. And it's crucial I get this right. If I decide, oh, that's diabetes, I'm going to give you an injection of insulin, I could kill someone. So it's crucial I get this right, and my treatment will match to some degree an idea of what might be causing those particular behaviors that the person is presenting with. Yeah? In other words, in psychiatry, we have a system of classification that is descriptive. It is not explanatory. Therefore, strictly speaking, there is no such thing as a psychiatric diagnosis. It's really important to understand. If you get caught in this trap that thinking a diagnosis explains, you will be caught in what's philosophically called a tautology. So let me run this one by you. Let me imagine that somebody is presenting with these behaviors of hyperactivity, poor attention, and the person I was seeing asked me, what do you think, doctor, what's causing these behaviors in my child, this poor attention, this hyperactivity? And I was to answer, oh, they're caused by ADHD. Well, a legitimate question for them to ask is, oh, how do you know it's caused by ADHD? Well, the only answer I can give, because they're hyperactive and have poor attention. It's the equivalent of saying, my headache is caused by a pain in the head. Yeah? If you want to use what we're calling diagnosis as a diagnosis, this is what you get caught up in. Our diagnoses can describe, but they cannot explain. If people understood this, we might not be in such a big mess. I can accept, because we have systems of classification for everything. It's one of the ways we make sense of the world around us. We try and group things together. I quite like the idea that you have in various biological sciences, in anthropology, in various social sciences, which use multiple classifications. So you use a system of classification in order for a particular purpose. So, for example, if you're studying a tribe, you might use a system of classification of temperature or climate, because there are different features of different tribes according to the climatic conditions they're facing. Or you might use a system of classification based on how gender relations happen, or on how hierarchy. The point is, when you're using it that way, you are aware this is a human construct. This is something that we're constructing as humans in order to try and make sense of something. And if you use that way of working with classifications, so you reject the diagnosis idea, but you use systems of classification, well, you'll find that the different therapy models out there all have different ways of classifying phenomena. And then you're aware that you're using a system of classification for a particular purpose that's therapeutic. Are you following me? So that's where I think we should be heading. So I'm going to just introduce you to a little bit of research, just to whet your appetite and to explain some of the basis of some of the things that has then informed some of the ways I've been thinking in engaging with those dilemmas that I outlined earlier on. So this is one of many studies. It's quite an old study, but it's a really good study because each arm of the 4 treatments, this is a large study on treatment of depression, and it was a very large study. It was a multi-center study, and it had 4 treatment arms. So people either got cognitive behavior therapy, interpersonal therapy, an antidepressant, or a placebo. And each arm, the patients had the same number of sessions. All the therapists had supervision. So there was a lot of work done on making sure that there was equal exposure in each arm. And each arm was run by therapists or practitioners who believed in the way of working that they were doing. And this is kind of fairly typical in terms of studies that are well done about what you find in terms of outcomes. There were no differences found in terms of who got better and how quickly between any of the 4 treatment arms. The things that made a difference were things like the patient's expectation. The more patients expected to get better, and the more hopeful they were that this intervention will be the one that will help them, the more likely they were to get better. And after that, the next big factor was their rating of the alliance at the 2nd session. So very early on, an idea about how they felt about the person that they were working with. In the longer term follow-up, people who got better from the psychotherapeutic approaches were much more likely to stay better, had a lower likelihood of relapse. But one of the interesting findings for me about this and many similar studies, I'm not going to go into all the nuances of placebo, but just to highlight, because I think placebo is just the wrong word. Simply seeing someone who had an interest in you, who talked to you, who helped you make sense, was not only as effective as prescribing an antidepressant, but was also as effective as highly structured psychological interventions like cognitive behavior therapy and interpersonal therapy. This was far more effective than these non-specific factors, rather, were far more effective, if you think about it, than any of the more specific factors. They were just things that went along. So this idea that if you match your diagnosis to your model has very little supporting evidence that these are the important things to improve outcome. I'll say a bit more about that in a minute. And if we look at placebo effects in studies, we'll find that if you're looking, to go back to my example of diabetes, placebo effects on blood sugar are almost non-existent. So in there, what I talked about as the technical model, it would seem to be really important. The technical model, when you're doing that, getting the diagnosis right in order to match the treatment is much more important than the bedside manner of the doctor. Yeah? But as you go up towards pain, for example, and then particularly towards psychiatric problems, these placebo effects get stronger and stronger. And here we're shifting more and more towards the importance of these non-specific factors, these relational factors, these human factors. So relational ways of working begin to affect the outcome a lot more. Am I making sense? So here is a kind of little graph that's showing a bit of the movement away from the centrality of the technical model towards the centrality of a different sort of model. And if we look at the literature on outcomes in general, this is what we find. Matching model or technique has no clinically significant impact on outcomes. Study after study, meta-analysis after meta-analysis, find, when they're done properly, something very similar to that study that I just mentioned. So the things that do have an impact on outcomes, by far the biggest is what we call extra therapeutic factors, things that people walk in the door with that has nothing to do with what we do in the consulting room. So their level of social support, family, level of education, personal expectations from what's going to work, this financial status, previous history, what's happened to you. All of these things have a much bigger impact on the likelihood of getting better than what we do in therapy. When it comes to therapy, quality of therapeutic alliance is king. It is the one that keeps coming out again and again. Therapeutic alliance is, of course, a very complicated thing with many, because it relies on what the patient's meaning system and the practitioner's meaning system, and these very difficult to define things like how you click with some people, how you don't with others. And these things happen quite quickly. And then there are a number of other things, such as regular monitoring of outcome. There's been studies on something called resource activation. So it seems that therapies, there's some research to suggest that therapies that also include not just a problem focus, but what's called a resource focus, how people have solved dilemmas, what their strengths are, what they have managed to achieve. You know, every story of trauma and suffering is often also a story of survival. So you can focus on the trauma, but you can also focus on how people survived. So aspects of resource activation seem also to be important according to some studies. Bringing that into your therapeutics, which gives a more hopeful therapeutic message. So in summary, with that outcome literature, and this is part of the thing that I teach people when I'm working with trainees, is when it comes to psychiatry, the technical model, which is a bit like the surgical model, in the technical model in mental health, it's a bit like the non-specific factors, because we do get taught about communication skills and the importance of the therapeutic relationship. But in the way we're taught it, it's a bit like the anesthetic. So you get patients under your spell, and once they're under your spell, you can get in there, you know, like the surgeon, to remove those automatic negative thoughts if you're doing CBT, or to get in there and correct that chemical imbalance that's going wrong. So you use relationship in order to deliver your preferred treatment. Follow me? That's the technical model, or the correct treatment. The relational model turns things on its head. You need models of working. You need frameworks to make sense. So you need different models of psychotherapy in order to conduct a meaningful exchange, in order to create the more non-specific things that appear to be where the differences happen. So in order to have a system in which you can engage with people in productive meaning making. Does that make sense? So relationship in context, which is where the evidence points to, is not an abandonment of models, but it's making models subservient to what's going to be meaningful. Some people really like homework. Some people really hate homework. Some people want to understand what's happened to them and how it's affected them. Some people are just too scared. They don't want to do that right now. So you need to develop and work with models that's going to help these relational aspects. And you're also going to have to be mindful of what's going on in the real life. Great, we're having these wonderful, meaningful conversations, but I'm still living at home, I'm alone, I've got no friends, I'm not doing anything, you know? Relationship in context. That's where it's at. That's where the evidence points. How many? 5. That was 5 fingers, wasn't it? Yes. So let's reconsider that framework that I presented at the first. Here we have this patient. They're presenting with persistent low mood. They've gone for cognitive behavior therapy. It's not helping. And now you're going to prescribe an antidepressant. What framework might you now think about? How might you use a model that actually acknowledges that the things that you're going to say, these non-specific factors, are far more important than any chemical effect? In fact, the chemical effect, according to my interpretation of the studies, certainly for antidepressants, is probably close to 0. The remaining 20% is probably related to, in the studies, people being unblinded, people realizing that they're taking the antidepressant because they've got side effects, and that kind of enhances some of those non-specific factors. So how might we? And here's just a few ideas. One of the first things that I ask people who are saying they're desperate for medication, and this is the only thing, you know, their friend has got medication, and I'm beginning to think, okay, if I don't prescribe medication, this has happened to me, they're going to not be happy with my opinion, they're going to go to my colleague, they'll end up getting medication anyway. And I'm also aware that quite often they might be interpreting, because this is such a widely held cultural belief nowadays, they might be interpreting that I don't think there's anything too much wrong with them, that I'm not validating their suffering. So one of the things I do is, before prescribing medication, I say something like, so let's imagine I have the perfect medication, and it's going to work absolutely perfectly for you, right? And you're going to take it. What is going to change in your life? So I first of all introduced the idea, you know, this is visualization of a different future by the back door. If I'm really lucky, and I've gone through all the side effects, and I often, when I prescribe, I sit there, I open my British National Formula, and I read out all the side effects, and there's usually there's tons, you know. So if I haven't put them off by then, and if I'm really lucky, and I say, well, before we prescribe, let's take these goals that you've had. You know, you've said you'll be. What's the easiest one from the goals that you've said? You're going to be talking to your friends more often. How about between now and the next time we meet, you work on that? Let's see what happens. You know, let's see. So sometimes even just doing that might find a way. But if they're still saying, you're getting the message that this is really not working for you, and you won't feel satisfied until you have that pill in your hand, then we set up an idea that these are the goals you're going to work on. And what I tell to people is, the thing you have to remember is this, okay? A medication does not make a decision, right? It's people who make decisions. Any change that happens will be your change. The way medication can sometimes help is it's a bit like you just needed a bit of oil to get the cogs turning again. So they can act as an enabler. So once you've got out of this loop that you've got stuck in and started making changes, those are the things that are going to make the long-term difference. This enables a different narrative framework for how we then work with people who then improve. You've already introduced the idea that medication is not a diagnostic treatment. It works to make something feel a bit different, to enable you to reconnect with parts of you that you've lost connection with. When you reconnect with them, they are the things that are going to make the change. So you've already introduced the idea that after a number of weeks or months, when the changes have happened and they've started to embed, you can start weaning a person off and reducing it. So this is the idea that it creates a window of opportunity. You follow me? Yeah? So we can play with various. So I train trainees to start thinking in those terms, in terms of medication as part of the psychotherapy, but how you deliver it has a big impact. There's all sorts of other things I can talk about. I've run out of time. I'll just tell you a little bit about working with people, because one of the real privileges in my role as a child psychiatrist is we often see people in the early stages experiencing psychotic, or what we call psychotic symptoms, and they're usually very meaningful experiences. And these are often contexts where medication is expected, and it can be helpful. And the model I use here is the idea of, in healthcare, we have a lot of interventions that actually have no therapeutic role, but they create a context. So, for example, I say that when we use plaster of Paris for a broken arm, the plaster of Paris does nothing. It's the body that does the healing. But for a period of time, it creates a context where your body is enabled to heal. So again, these are playing around with narrative frameworks to introduce the idea that the prescriptions are for a limited time only, while we do the important stuff about helping you move forward and make meaning. One of the things that I've found really helpful in the people that I've worked with is talking with them about changing how they might change their relationship with the experiences they're having. So people who are hearing voices, we personalize the voices, we try and understand who they might come from, and we talk about their relationship. Do they feel controlled by the voices? Do they feel the voices persecute them? How might they change their relationship? Sometimes it's as simple as giving the voices a name. Sometimes it's to do with making time to talk back to the voices and asking them questions. Sometimes it's to do with how you might ignore the voices and what happens to them if you ignore. There's all sorts of different ways of exploring how you change their relationship. I know, I finished. I was going to say something about some of the outcomes. We've had some really good outcomes with the model that we've been using in the team. People do get better, they get discharged, they don't become chronic patients. A lot of the national data says that that we are still continuing to create chronic patients with using the diagnostic model. And I will finish
Thank you so much, Sami. And I just